Chapter 29, Head and Spine Injuries. The National EMS Education Standard Competencies for this chapter, trauma, applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. The chapter will focus on head, facial, neck, and spine trauma. We'll be looking at life threats and specific injuries to the spine. We look at the pathophysiology and assessment and management of spine trauma and skull fractures. This chapter will also cover injury to the nervous system. So we'll be looking at the pathophysiology and assessment and management of traumatic brain injury and spinal cord injury. Introduction. The nervous system is a complex network of nerve cells that enables all parts of the body to function. It includes the brain, the spinal cord, nerves, and nerve fibers. The nervous system is well protected. The brain is protected by the skull. The spinal cord is protected by the spinal canal. Despite this protection, serious injury or injuries can damage the nervous system. So even though it's well protected, if the force applied to the area is significant, these structures can be injured. Let's review the anatomy and physiology of the nervous system. The nervous system is divided into two anatomic parts. You have the central nervous system, which consists of the brain and the spinal cord. And you have the peripheral nervous system, which consists of the cranial nerves and spinal nerves. And we have 12 pairs of cranial nerves and 33 pairs of spinal nerves. No, 31. The nervous system has two anatomic components, the central nervous system and the peripheral nervous system. The central nervous system is composed of the brain and the spinal cord. Peripheral nervous system conducts sensory and motor impulses from the skin and other organs to the spinal cord. Let's look at the central nervous system. The central nervous system, it includes the brain and spinal cord. The brain controls the body and it is the center of consciousness. And the brain is divided into three major areas. You have the cerebrum, which is the largest portion of the brain. You have the cerebellum or midbrain, and you have the brainstem, which is the smallest portion. The cerebrum is responsible for all conscious thoughts and functions. Anything that requires us to think about it, it is going to be the cerebrum. That's the role of the cerebrum. The cerebrum is divided into the right and left hemisphere. So it's divided into two hemispheres. The right hemisphere controls function on the left side of the body. The left hemisphere controls functions or movement on the right side of the body. Let me repeat that. So the cerebrum is divided into the right and left hemisphere. The right side or right hemisphere controls movement on the left side of the body. Left hemisphere control movement on the right side of the body. Now, the right side of the brain is responsible for how our speech sounds when it comes out. The left side of the brain is responsible for how we interpret and understand speech. So the right side is how the speech sounds when it comes out. The left side is how we interpret or understand speech. That's the cerebrum. So it's responsible for all the conscious functions within the body. Everything that we are required to think about, it's gonna be the cerebrum. The cerebellum, you will use the B and L in cerebellum to remember balance and coordinated movement. And that is what the cerebellum is for. It is responsible for balance and coordinated movement. The brainstem is the smallest portion of the brain, and it is the most well protected because it is responsible for all life sustaining function, breathing, the heart. Everything that sustains life is the brainstem. The brain is part of the central nervous system and is the organ that controls the body. It is divided into three major areas: the cerebrum, the cerebellum, and the brainstem. The cerebrum controls a wide variety of activities, including most voluntary, motor function, and conscious thought. As I stated earlier, everything that we must think about is going to be the cerebrum. That's its function. It contains about 75% of the brain's total volume, and it is divided into two hemispheres with four lobes. And these four lobes are the frontal lobe, parietal, temporal, and occipital. And each lobe has specific functions. The cerebellum or midbrain is responsible for coordinated balance and movement. So it's balance and coordinated movement. The brainstem controls most functions necessary for life, and it is the most well-protected area of the brain. The spinal cord is the connection between the brain and the rest of the body. So the spinal cord is made up of fibers that extend from the brain nerve cells and carries messages between the brain and the body via the gray and white matter of the spinal cord. The protective coverings. So the entire central nervous system is contained within a protective framework. The thick, bony structures of the skull and the spinal canal can withstand injury very well. The CNS is further protected by the meninges, and the meninges is the membrane that covers the brain, and it has three layers: dura mater, pia mater, and the arachnoid layer. Three layers or three areas. The dura mater is a tough layer of the membrane. The pia mater is a soft layer. The arachnoid is where most of the blood vessels are located. Learn the position of these membranes or of these layers, because bleeding can occur above or below any one of these layers. So make sure you know them. Now, the meninges, the outer layer is a dura mater. This is a tough fibrous layer that forms a sac to contain the CNS. The inner two layers are the arachnoid and the pia. So it's the arachnoid matter and the pia matter contain the blood vessels. Here is a soft layer. And same as how it is laid out on this diagram, make sure you commit that to memory, because bleeding can occur. So bleeding can occur above the dura. So you can have bleeding occurring above the tough layer and between the skull. You can have bleeding occurring below the tough layer, and you can have bleeding in the arachnoid space. So make sure you are familiar with the layers of the meninges. Which layer is the top layer, which layer is the middle, and which layer is the bottom layer. Make sure you're familiar with the positions. The central nervous system has several layers of protective covering: the skin, muscles, their fascia, the bone, and the meninges. The three layers of the meninges are the dura mater, arachnoid, and pia mater. Cerebrospinal fluid. Now, cerebrospinal fluid is produced in a chamber inside the brain called the third ventricle. It is approximately 125 to 150 mils of CSF in the brain at any time. And this fluid is present as a shock absorber. So it protects the brain from impact, cushions the brain. Also, and there is also cerebrous fluid or spinal fluid in the spinal canal as well to cushion the spinal cord. Now we have 31 pairs of spinal nerves. They conduct impulses from the skin and other organs to the spinal cord, and they conduct motor impulses from the spinal cord to the muscles. And you can, on this diagram, you can see where the spinal cord exits the foramen magnum, that opening in the skull. And as it comes down, you have nerves branching out at the shoulder. That's the brachial plexus. And then when it goes down to the lumbar area, you have the lumbar sacral plexus and nerves going to the lower extremities. The peripheral nervous system is a complex network of motor and sensory nerves. The brachial plexus controls the arm, and the lumbosacral plexus controls the legs. Pretty straightforward. We have 12 pairs of cranial nerves, and they transmit information directly to or from the brain, and they perform special functions in the head and face. Some of these functions include sight, smell, taste, hearing, and facial expressions as the cranial nerves. Now, within the peripheral nervous system, two types of peripheral nerves are important for us to be familiar with. You have the sensory nerves, which carry only one type of information from the body to the brain via the spinal cord. So the sensory nerves picks up sensations from the environment and relay that information to the brain. The motor nerves go directly to muscles. So there is one for each muscle. So the motor nerves carry information from the brain to the muscles to carry out movements. And the connection between the sensory and motor nerves is the connective nerves. So you have connective nerves that join the sensory and motor nerves. Connecting nerves, found only in the brain and spinal cord, connect the sensory and motor nerves with short fibers, allow the exchange of simple messages. So connective nerves are present in the brain and spinal cord, and the role is to relay messages quickly from sensory to motor. So these messages do not go to the brain, they bypass the brain. This is what we would refer to as a reflex action or a reflex arc or a spinal reflex. So it's a function or movement that doesn't require the brain function, or we need to bypass the brain function. In other words, if I pick up something that is hot and it is burning my fingertips, I am not going to think about, okay, this thing is burning my fingertips. I need to let go my index, then my thumb, and then no, I'm not going to think about it. Immediately, once the heat sensation is picked up by the sensory nerves, it's going to travel to the spinal cord and go to the connective nerves, and then it will go to the muscles, and the muscles will return that signal to the fingertips. Sorry, the motor nerves will return that signal to the fingertips, and then I'll release it. So it's bypassing the brain. That's a reflex arc. How the nervous system works. So it controls virtually all body activities, and these activities includes reflex activities. Already explained that. So a reflex activity means it bypasses the brain. It's a movement that needs to occur without brain function. Voluntary activities, these are activities that the brain controls, and involuntary activities, the brain does not directly control those activities. Connective nerves in the spinal cord form a reflex arc. If a sensory nerve in this arc detects an irritating stimulus, it bypasses the brain and sends the message directly to the motor nerve. I've already explained that. That's a reflex action or spinal reflex. So the connecting nerves in the spinal cord form a reflex arc. If a sensory nerve in this arc detects an irritating stimulus, it will bypass the brain and go straight to the motor nerve, because we need to create, the body needs to create that movement quickly. Body is in danger. Still on how the nervous system works, voluntary activities are activities we consciously perform. Involuntary activities are the actions that are not under conscious control, and somatic voluntary nervous system handles voluntary activity. So the peripheral nervous system further breaks down into what we would refer to as the autonomic and somatic nervous system. The somatic deals with voluntary movement. The autonomic deals with involuntary functions. So the autonomic is the involuntary nervous system, and it handles body functions. It is divided into two sections. Right? So you need to ensure that you understand the breakdown. So the central nervous system consists of the brain and the spinal cord. The central nervous system then breaks down into the peripheral nerves and the spinal nerves. That is your peripheral nervous system. The peripheral nervous system then breaks down into the autonomic and somatic nervous system. The autonomic further divides into what we would refer to as the sympathetic and parasympathetic. And this is how I remember it. So I always tell students that S in sympathetic, think of it as speed. So the S in sympathetic system, think of it as speed. So the sympathetic nervous system speeds up body functions. This is the portion of the nervous system that will produce adrenaline or epinephrine and noradrenaline or norepinephrine. So it is the fight or flight system. It speeds up the body functions, heart rate, breathing, right? Increases body functions. The parasympathetic, the word para, the prefix para is half. So that's what para means. It means half. So para, if sympathetic, the S represents speed, then parasympathetic means half speed. So the parasympathetic system or nervous system slows down functions. The parasympathetic system is the system that is working when you have eaten your dinner or your lunch, and your brain activity start to slow down and you start to get sleepy. That's a parasympathetic. So it slows down functions. It is the rest and digest system. And the sympathetic is the fight or flight. So the sympathetic nervous system reacts to stress, which is a fight or flight response, and the parasympathetic nervous system has the opposite effect on the body. Now let's look at the skeletal system. Let's review it. In the skeletal system, you have the skull, which is composed of two groups of bones, the cranium and the facial bones. The brain connects to the spinal cord through the foramen magnum. That's the opening at the base of the skull. There are four major bones that make up the cranium, and the name of these bones is the same name for the lobes of the brain: occipital, temporal, parietal, and frontal. The face is composed of 14 bones, and the ones that you need to be familiar with are the maxillae, zygomas, mandible, and orbit. Now, the spinal column, the body's central supporting structure, consists of 33 vertebrae, and they are divided into 5 sections. You have the cervical, thoracic, lumbar, sacral, coccygeal, or coccyx, which is fused. And each area of the spinal column have a certain amount of vertebrae. So the cervical area has 7, the thoracic has 12, lumbar 5, sacrum 5, and they are fused, coccyx 4, and they are fused. So the spinal column is the body's central supporting system and consists of 33 bones divided into 5 sections. Injury to the vertebrae may cause paralysis. Very important point to note. So if there is injury in any area of the spine, it can cause paralysis below it. Wherever that injury is, there can be paralysis below the injury. And this is why it's extremely important when you suspect that a patient has a significant mechanism of injury that can compromise the spine, you move the patient without causing flexion or extension and rotation of the spine. We don't want to cause long-term damage when moving these patients. Now, the spinal column. Injury to the vertebrae can result in paralysis. Vertebrae are connected by ligaments and separated by cushions called intervertebral discs. Spinal column is almost entirely surrounded by muscles. And that's the review of the anatomy and physiology of the nervous system. Now let's look at the injuries. Head injuries. That's the one we're starting with first. Head injuries. Traumatic insult to the head that may result in injury to soft tissue, bony structures, or the brain itself. It accounts for more than half of all traumatic deaths. The patient may have sustained additional trauma. So this is the worst trauma patient you can get. A patient with head injury and the brain is damaged. Now, a head injury can be closed or it can be open. So closed injuries, the brain has been injured, but there is no opening into the brain. Open injuries, an opening from the brain to the outside world exists, often caused by penetrating trauma, maybe bleeding, and exposed brain tissue. So you might see this patient with bleeding and the brain tissue may be exposed. Now, falls and motor vehicle crashes are among the most common MOI. So most head injuries are going to be linked to falls and motor vehicle crashes. Head injuries also commonly occur in victims of assault and during sports related incidents, especially contact sports, boxing, kickboxing, MMA, rugby, American football, ice hockey. These are sports that have a high incidence of head trauma. Here's attention to table 29-1, which covers the signs and symptoms of head injury. Scalp lacerations. A scalp laceration can be minor or it can be serious. Even a small laceration can lead to significant blood loss because the scalp is highly vascular. And it may be so severe that the patient starts to present with signs and symptoms of shock. They are often an indicator of deeper or more serious injuries. Skull fracture. To fracture the skull, it takes significant force to crack the skull. So if a patient has a skull fracture, more than likely the brain is going to be significantly affected. Significant force applied to the head may cause a skull fracture. May be open or closed dependent on whether there is an overlying laceration of the scalp. Injuries from bullets or other penetrating weapons often result in skull fractures. Signs of skull fracture include the patient's head appears to be deformed. There is visible cracks in the skull. There is ecchymosis, which is bruising that develops under the eyes, which is sometimes referred to as raccoon eyes. And these are the ecchymosis or the raccoon eyes is something that doesn't develop right away. So you're not going to see it right away. So don't use it as a telltale sign to rule out a skull fracture. Ecchymosis that develops behind one ear or over the mastoid process that is referred to as battle sign. Again, this ecchymosis is not something that will occur right away. It will develop as the bleeding gradually occurs. So it's a late sign. And these two pictures show the top one is the raccoon eyes, the bottom one is the battle signs. Signs of skull fractures or fracture include ecchymosis under the eyes, raccoon eyes, or behind one ear over the mastoid process, battle sign. The linear skull fracture, which is extremely common. So linear skull fracture accounts for about 80% of all skull fractures. It is not going, the patient will not present with visible deformity. This type of fracture, a radiograph is usually required to diagnose it because you're not seeing any deformity. Depressed skull fractures. A depressed skull fracture requires high energy. There needs to be high energy impact involved when this fracture occurs. So it results from high energy direct trauma to the head with a blunt object. The frontal and parietal bones are most susceptible to this type of force. Bone fragments may be driven into the brain and can cause injury to the brain. Then you have the basilar skull fracture, the base of the skull. This fracture is also associated with high energy impact or trauma, usually occur following diffuse impact to the head, and the signs include CSF draining from the ears, which is the battle signs, and blood pooling around the eye area, that's the raccoon eyes, ecchymosis. Ecchymosis behind the ears and around the eyes is associated with a basilar skull fracture. And this is a patient in which you will see CSF or fluid draining out of the ears. And if you see anything like that, you don't try and control that bleeding. You allow it to run. We don't want to create pressure going back into the skull onto the brain. So we don't create any pressure when we see that type of bleeding occurring. Now, open skull fractures, often associated with trauma to multiple body systems. The brain tissue may be exposed to the environment. These type of patients have a high mortality rate, so quite a few of them tend not to survive. Now, traumatic brain injuries, most serious of all head injuries. So this is the worst head injury a head injury patient can get. Two broad categories. So you have primary direct injury and secondary indirect. The primary direct injury is injury to the brain tissue itself. So primary brain injury results instantaneously from impact to the head. And the secondary brain injury is the complications associated with the severity of the primary injury. So the complications of the initial injury is the secondary brain injury. So secondary injury may be caused by, and all of these complications are linked to a primary brain injury. So secondary injury may be caused by hypoxia, hypotension, cerebral edema. When you see the word edema, edema means swelling and leakage of fluid. So edema is associated with swelling and leakage of fluid. Intracranial hemorrhage, increased intracranial pressure, which is very terrible for the body. Cerebral ischemia. The word ischemia means lack of oxygen. That's what ischemia means. So don't confuse ischemia with hypoxia. Hypoxia is low oxygen. Ischemia is lack of oxygen. Infection. The brain can be injured directly by a penetrating object or indirectly as a result of external forces. And a patient can get coup contre coup, that's how it's pronounced, it's French, coup contre coup injury. And it simply means that there's an injury to the front portion of the brain and the back portion of the brain. Or it can be there's an injury to the left side of the brain and an injury to the right side. Coup contre coup, it's French. So the coup contre coup injury can result from striking a windshield. The head hits the windshield, the brain comes forward to an abrupt stop by striking the inside of the skull, and when the head goes back against the headrest, the brain slams on the rear portion of the skull. So there are 2 points of injury. Cerebral edema may not develop for several hours. So it's not going to be an acute occurrence for edema. It's something that gradually develops. Low blood oxygen levels aggravate cerebral edema. Very important. So if there is edema occurring and there is low blood flow to the brain, it's going to make it worse. Monitor the patient for any seizure activity. Now, intracranial pressure. This is the accumulation of blood within the skull or swelling of the brain can rapidly lead to an increase in ICP. So this is a pressure. There needs to be a specific pressure inside of the brain, inside of the skull, to allow the brain to be properly perfused. If something alters this pressure, it can cause complications for the brain, and it can be altered from blood or bleeding occurring on the brain, and it can be altered from the brain itself, swelling. So bleeding and swelling can cause an increase in intracranial pressure. Why this is so dangerous for the body is that once the ICP starts to rise, how the body compensates for this rise actually makes it worse. So when the body detects that intracranial pressure is going up, it will increase the blood pressure. So the body is going to try and increase the patient's blood pressure. So what is going to happen is the blood vessels in the brain that feed the brain are going to open up to get more blood going to that area. Now, if the brain is already swelling and there is bleeding occurring in the brain, that's just going to make it worse. So again, ICP is very bad for the patient because how the body compensates for it actually makes it worse. So a trauma patient who has elevated ICP is in serious trouble. Now, signs of increased intracranial pressure. You're gonna see the Cheyne-Stokes respiration. And that's the one where the respirations go up, slow down, pause, go up, slow down, pause. So it's irregular, but it's consistent in its irregularity. That is associated with increased intracranial pressure. The patient can also have a tachyc-biot respirations. This is the breathing pattern that is irregular. So there is no pattern, no distinct pattern to this patient's breathing. It's erratic. That's associated with increased intracranial pressure. The patient can also have decreased pulse rate, which is very important, a very important finding. headache, nausea, vomiting. Vomiting is common with head injury patients. Decreased alertness, bradycardia, sluggish or non-reactive pupils, decerebrate posturing, that's the extremities stiffening up, the legs stiffening up, and the arms coming into the core of the body, an increase or widened blood pressure, and they can have what is called Cushing reflex or Cushing triad. Cushing reflex is you're going to see the breathing pattern slow down. So the patient is going to be breathing slow, the blood pressure is going to rise, and the pulse rate is going to drop below 60. That is Cushing triad. Slow breathing, elevated blood pressure, slow pulse. These are key findings that tells you that your patient brain may be herniating. The pressure is so significant that this patient might have herniation of the brain. Intracranial hemorrhage. Bleeding inside the skull also increases ICP. Bleeding can occur between the skull and the dura mater. If it's between the skull and the dura mater, this is referred to as epidural because it's above the dura. If it's beneath the dura mater but outside the brain tissue because it's below the dura mater, it is referred to as subdural bleeding. And bleeding can occur within the brain tissue itself, intracerebral bleeding. So let's look at an epidural hematoma. A hematoma is a collection of blood within various areas of the body, and it's usually going to occur from a fairly large blood vessel. So epidural hematoma, another way of thinking about a hematoma is when we used to ramp when we're small and we lick our head and get a cocoa. That's a hematoma. But a hematoma is not specific to your forehead. It can occur anywhere in the body. So epidural hematoma is the accumulation of blood between the skull and the dura mater. It nearly always the result of a blow to the head that produces a linear fracture, and it's going to be an artery that is bleeding. So this patient who gets an epidural hematoma, the patient is going to get hit in the head. They are going to lose consciousness when they get hit in the head, and then they are going to regain consciousness. When they regain consciousness as the bleeding occurs, they will start to lose consciousness again slowly, and then they go unresponsive. That's how these patients present. An epidural hematoma is usually the result of a blow to the head that produces a linear fracture of the temporal bone and damages the middle meningeal artery. And the word linear means it's in a line. Blood accumulates between the dura mater and the skull, so it's above the dura. That's why it is referred to as an epi. The prefix epi means above, epidural hematoma. Now, the subdural hematoma, this is the one now that is below the dura mater, and this one is common in geriatric patients. So an elderly, as patients get, well, as we get older, the brain tissue shrinks. So the brain tissue starts to shrink, and there is more space available between the skull and the brain. And sometimes these elderly patients fall and hit their head. Right? So they hit their head. They don't necessarily lose consciousness, but they hit their head. And what is going to happen? It's not an artery that's bleeding, it's a vein. So it's going to be slow. The bleeding occurs slow. And as the bleeding occurs and starts to irritate the brain, family members are going to observe changes in these elderly persons. So how they interact, they're going to start to see a change in their interaction. The patient will gradually develop what is called an altered mental status, and then they will go unresponsive. And this is going to happen over a period of days. It's not like the epidural hematoma, which is sudden. So subdural hematoma, accumulation of blood beneath the dura mater, but outside the brain. It occurs after falls or injuries involving strong deceleration forces. May or may not be a skull fracture present. Intracerebral hematoma. So this is the one that is occurring within the brain tissue itself. Bleeding within the brain tissue itself can occur following a penetrating injury to the head or because of rapid deceleration forces. The patient can also have a subarachnoid hemorrhage, and all that means is the bleeding is occurring underneath the arachnoid layer. So it's directly irritating the brain. Because it's directly irritating the brain, this patient will often complain of a severe headache. So they will get severe headache. They can also present with vomiting. So subarachnoid hemorrhage, bleeding occurs into the subarachnoid space where the CSF circulates, results in bloody CSF and signs of meningeal irritation. Common cause include trauma or rupture of an aneurysm. And an aneurysm is a weak point in an artery. So it's a weak area in the artery that ruptures. Now let's look at a concussion. A concussion is a blow to the head or face. It may cause concussion of the brain, close injury with a temporary loss of alteration of part or all of the brain abilities to function without demonstrable physical damage to the brain. So the person, the individual gets hit in the head or face and the brain is jarred, but there is no physical injuries to the brain, but the patient is presenting with signs and symptoms as if the brain is injured. About 90% of the patients do not experience a loss of consciousness. So most persons won't have a loss of consciousness. Some will, especially in contact sports. So this happens a lot in the contact sports like boxing and mixed martial arts. Gonna happen a lot, and these persons can develop what is called concussion syndrome. So they get what is called repeated concussion, and when they start to get older, they start to have cognitive decline and altered behaviors. Now, why it's so common in contact sports is because most contact sports require persons to cut weight, and that can put the brain at risk for concussive or concussion injuries. And how that happens is like this. So most persons have to fight in a weight class. So let's say I walk around at 180 pounds. Right? So I'm 180 pounds, but my weight class, the weight class that I fight in, is 155. So I have to cut down to 155. And what most of these fighters do is they're not really cutting weight, they're cutting water. They're basically dehydrating their body so that when they step on the scale, they weigh 155, and then after they come off the scale, they try to rehydrate their body for the fight to get back up to their natural weight, which would be the 180. Now, the issue with that is you can rehydrate other areas of the body fairly quickly, but you cannot rehydrate the brain very quickly. It takes time to rehydrate the brain. And when a cell is dehydrated, it shrinks in size. That's what happens to the cell. Give me a sec. Sorry about that. So when a cell is dehydrated, it shrinks in its size. And the brain takes roughly 24 hours. It can take longer than that to rehydrate. So a lot of these fighters go into the ring with the brain not fully rehydrated. And then they are at risk because there is more space inside the skull. So if they get hit, they can be knocked out easily and they can develop concussion injuries, or they can get concussion syndrome, which is a long-term issue. So that's concussions. A patient with a concussion may be confused or have amnesia. Usually a concussion lasts only a short time, and they can have an amnesia as a result to what happened before the incident, or they can have amnesia as a result of what the amnesia may be they can't remember what happened after, or they can't remember what occurred before. So it can be retrograde amnesia or antegrade amnesia. Now, ask about these symptoms: dizziness, weakness, visual changes, nausea and vomiting, ringing in the ears, slurred speech, inability to focus. So that's your concussion. Now remember, with the concussion, there is no physical injury to the brain identified, but the patient is presenting with signs and symptoms as if the brain is physically damaged. A contusion, no. This is far more serious than a concussion because there is physical injury occurring to the brain tissue. May sustain long-lasting and even permanent damage. A patient may exhibit any or all of the signs of brain injury. That's your contusion. Other brain injuries can also arise from medical conditions such as blood clots or hemorrhages. So a patient can get brain injuries from a stroke. Signs and symptoms of non-traumatic injuries are often the same as those for signs and symptoms of non-traumatic injuries are often the same as those of traumatic brain injuries. So if it's a stroke patient, you're going to see the same signs and symptoms in comparison to a patient who has physical damage, trauma. Same signs and symptoms. And when it's an area of the brain, the function that is absent will be specific to that area of the brain. But if the entire brain is affected, the entire body will be affected. Now let's look at spine injuries. Compression injuries can result from a fall. Forces that compress the patient's vertebral body can cause herniation of discs. Motor vehicle crashes can overextend the spine. Rotation, flexion injuries of the spine result from rapid acceleration forces. When the spine is pulled along its length, this is referred to as hyperextension. It can cause fractures. Any one of these unnatural motions, as well as excessive lateral bending, can result in fractures or neurologic deficit. When bones of the spine are altered from traumatic forces, they can fracture or move out of place. And those are your injuries. Now let's look at the patient assessment approach for patients with head and spine injuries. Patient assessment. Always suspect a possible head or spinal injury with motor vehicle collisions, pedestrian versus motor vehicle collisions, right? Pedestrian versus motor vehicle always win. Falls, blunt trauma, penetrating trauma to the head, neck, back, or torso. Always suspect a possible head or spinal injury with rapid deceleration injuries, hangings, axial loading injuries, diving accidents. Scene size up, scene safety. Evaluate every scene for hazards to your health and the health of your team or bystanders. Be prepared with appropriate standard precautions. Call for ALS as soon as possible. Mechanism of injury or nature of illness. Look for indicators of the MOI, and if you found the MOI, is it significant or insignificant? Is it localized or diffused? Consider how the MOI produced the injuries expected. After we have completed the scene size up, which is you ensure that the scene is safe, you take the appropriate standard precautions for yourself and your team members. You identify the mechanism of injury or nature of illness, how many patients you have to deal with, or how many patients you need to assess and manage, whether or not you need additional resources, and start to think about whether or not you will need to use spinal motion restriction or spinal immobilization. Once you have completed your scene size up, the next phase of your assessment is the primary assessment. Focus on identifying and managing life-threatening concerns, reduction of unseen time, and recognition of a critical patient increase the patient's chance for survival or a reduction in the amount of irreversible damage. Do not delay transportation for a critical trauma patient. Time is important for these patients. So you want to manage the ABCs within 6 minutes. Within 6 minutes, we should be getting ready to package the trauma patient that is critical and get them off location. If it's a critical trauma patient, is only surgical intervention going to save this patient? We cannot do that in the field. Spinal immobilization considerations. Assess the patient in the position found. Now, if you suspect spinal injury, you always approach the patient in the line of vision or the line of sight or in a neutral position. You approach the patient in a way where they have to look to find where you are. If they have a spinal injury, that can compromise the spinal injury. So assess the patient in the position found. Determine whether or not a cervical collar needs to be applied. Assess the scene to determine the risk of injury. Form a general impression based on the level of consciousness and chief complaint. The backboard often places the patient in an anatomically incorrect position for a long period of time. So when we use a spine board, keep that in mind. Circulation to areas of the skin may become compromised. Some patients could experience respiratory compromise while lying flat because the alveoli start to collapse or close up. Try to minimize the amount of time a patient is on a backboard. Very important. And most protocols now do not keep the patient on the spine board. So most protocols move the patient with a scoop. Once the patient gets to the stretcher, they are removed from the scoop and the patient is immobilized on the stretcher with a C-collar and head blocks. That's the current guidelines. Try not to keep your patient on a spine board for too long. There's research that supports that patients, geriatric patients being on a spine board for 30 minutes can start to have skin issues. Their skin can start to break down. There's research to support that. So do not keep that patient on the spine board for too long. Cervical collar helps maintain spinal motion restriction. The best time to apply a cervical collar depends on the patient's injuries. Once the cervical collar is on, do not remove it unless it causes a problem with maintaining the airway. And students always ask me when to put on a cervical collar. And this is what I always tell students. Don't put on a cervical collar until you have assessed your ABCs. So you need to cover your ABCs before you put on a C-collar on your patient. Manage your life threats first. A C-collar will not save a patient's life. A C-collar cannot save a patient's life. It is just there as motion restriction and it doesn't do that very well. ABCs first, then rapid scan. While doing your rapid scan, when you get to the neck, put on your cervical collar. That's my approach. Not gonna see me put on a cervical collar on a patient and assessing ABCs, because if the ABCs are compromised, I will have to take the collar off. That would be me working backwards, and I don't work backwards. I always work forward. Assessing for signs and symptoms of head or spine injury. Ask about the chief complaint. Is there confused or slurred speech? Is there repetitive questioning or amnesia in responsive patients? Sorry. Amnesia in responsive patients are good indicators of head injury. In the setting of trauma, assume your patient has a head injury until your assessment proves otherwise. So if you suspect that the mechanism is diffuse, take the necessary spinal motion restriction precautions or your spinal immobilization precautions and transport your patient until they can rule it out at the hospital. And the new term is really spinal motion restriction because we cannot immobilize the spine. Nothing that we do as medics, as responders, can immobilize the spine. The backboard does not immobilize the spine. It restricts the motion of the spine, but it doesn't immobilize the spine. Same thing with the C-collar. Does not immobilize the cervical collar, it just restricts the motion. So the new guidelines refer to it as spinal motion restriction. It's no longer referred to as spinal immobilization. Assessing for signs and symptoms of head or spine injury. Unresponsive trauma patients should be assumed to have a spinal injury. Patients with decreased level of responsiveness should be considered to have a spinal injury based on their chief complaint. Assess airway, breathing, and circulation. If you see anything wrong, make your adjustments. So airway breathing and circulation considerations, use a jaw thrust maneuver to open the airway. If the jaw thrust maneuver is ineffective, use the head tilt chin lift maneuver as a last resort. Vomiting may occur in the patient with head injury. This is very common. Irregular breathing may result from increased ICP. Look out for your Cushing reflex or Cushing triad. Elevated blood pressure, bradycardic pulse, slow breathing. Oxygen is always indicated for patients with head and spine injuries. Pulse oximeter values should be maintained above 90%. Do not allow these patients to go below 90% because it will affect the entire brain. So they need to have good cerebral perfusion or perfusion of the brain. Hyperventilation should be reserved for specific conditions, and your medical director may order you to hyperventilate if the patient is having signs of raised intracranial pressure. A pulse that is too slow in a setting of a head injury can indicate a serious condition. A single episode of hypoperfusion in a patient with a head injury can lead to significant brain damage and even death. Assess for signs and symptoms of shock, control bleeding. The manner of transport. Patients with impaired airways, open head wounds, or abnormal vital signs may need to be rapidly extracted from a motor vehicle and transported. Ensuring a patent airway and providing supplemental oxygen is paramount. Suction should be readily available. Maintain immobilization of the spine. Once we have completed the primary assessment, you should be able to answer some questions. One, what is the patient's GCS? Right? So after you have done your LOC assessment, assess and manage airway, assess and manage ventilation, oxygenation, and respiration, assess for bleeding and control it, check pulse, rate, rhythm, and strength, skin color, temperature, hydration, cap refill. Once you have assessed and managed your ABCs, you should have some questions to answer. One, what is the patient's GCS? Two, is it a load and go patient or a stay and play? Three, does this patient requires a rapid scan or focus? That comes after your ABCs. And of course, what is the priority? What is the priority? So after the primary assessment, the next phase is your history taking. Investigate the chief complaint, obtain a medical history, and be alert for injury-specific signs and symptoms. Using the OPQRST may provide some background on isolated extremity injuries. Gather as much sample history as you can while preparing for transport. So if the patient can talk, talk to the patient. If the patient can talk to the patient. Patient not talking, focus on physical findings and your vital signs. After the history taking phase, then you have your secondary assessment. Instruct the patient to keep still and not to move the head or neck. Physical examinations may be a systematic head to toe, full body scan, or systematic assessment that focuses on a certain area or region of the body. Physical examinations, we need to get our recorded vital signs. So get your vital signs, compare it to your primary assessment, determine if your patient is trending up or down. Significant head injuries may cause the pulse to be slow and the blood pressure to rise. That's signs of herniation. With neurogenic shock, the blood pressure may drop and the heart rate may increase to compensate. Know the difference. Respirations will become erratic. Use your monitoring devices. Use your DCAP BTLS IC to examine the head, chest, abdomen, extremities, and back. Check perfusion, motor function, and sensation in all 4 extremities prior to moving the patient. A decreased level of consciousness is the most reliable sign of a head injury. Look for leaking blood or CSF. Assess pupil size and reaction to light and continue to monitor the pupils. Do not probe open scalp lacerations with your glove finger. For your neurologic examination, perform baseline assessment using your Glasgow Coma scale, which looks at eye-opening, motor response, eye-opening, verbal response, and motor response. If you don't know it yet, write it down and learn it. If your jurisdiction uses the revised trauma score, then the findings from the GCS will be used in determining the RTS value. Record levels of consciousness that fluctuate or deteriorate. And this is your Glasgow Coma scale. Write it down somewhere in your book, screenshot it, learn it. When you come to do your final practical, I will need a GCS finding for the patient. You will have to tell me what the GCS is, and you will have to tell me how you calculated it. So if you didn't learn it prior to your patient assessment exam, make sure you learn it going forward. Make sure you learn it going forward. So it's eye-opening, verbal, and motor response. EVM 4, 5, 6. So the best score is going to be 15. Anything below 9 is significant. So anything below 9 would be significant, and you need to be prepared to manage that patient's airway. Spine examination, inspect for DCAP BTLS IC and check the extremities for circulation, motor, and sensory problems. If there is impairment, note the level. Pain or tenderness when you palpate is a warning sign. Other signs and symptoms include deformity, numbness, weakness, or tingling in the extremities, and soft tissue injuries. After you have completed your secondary assessment, the final phase of your patient assessment would be your reassessment. So repeat the primary, repeat LOC, airway, breathing, circulation. Reassess your vital signs, look for your trends. Is your patient trending up or down? Think about the chief complaint. Recheck the patient's intervention. Reassess at least every 5 minutes if critical, every 15 if stable. Do your proper documentation. Notify the receiving facility. All of that is a part of your reassessment. So interventions, compare baseline vital signs with repeated vital signs. Rapid deterioration of neurologic signs is a sign of an expanding bleeding in the brain or rapidly progressing brain swelling. If CSF is present, cover the wound with a sterile gauze, but do not bandage tightly. Administer high flow oxygen, apply a cervical collar. communication, and documentation. Your documentation should include the history you obtain at the scene, your findings during your assessment, treatment you provided, how the patient responded to them. Document vital signs for unstable patients every 5 minutes, every 15 for stable patients. Now let's look specifically at emergency medical care of head injuries. 3 general principles. Establish an adequate airway. Establish an adequate airway. Ensure that the patient has an airway. Don't be in a hurry to put a cervical collar on the patient. Make sure the patient has an airway. Control bleeding and provide adequate circulation to maintain cerebral perfusion. Assess the patient's baseline level of consciousness and continuously monitor the patient's level of consciousness. Managing the airway. Perform the jaw thrust maneuver. Once the airway is open, maintain the head and cervical spine in a neutral inline position until you have placed a cervical collar and have secured the patient on a backboard. And that's what that would look like. So someone is maintaining inline stabilization of the head. The person with who is applying the collar would be responsible for assessing airway, breathing, circulation, managing and providing appropriate management, and that person would be the person responsible for putting on the cervical collar once it is sized properly. Remove any foreign bodies, secretions, or vomitus. Check ventilation. Give supplemental oxygen to any patient with suspected head injury. For circulation, begin CPR if the patient is in cardiac arrest. Active blood loss aggravates hypoxia. You can almost always control bleeding from a scalp laceration by applying direct pressure over the wound. Shock. Shock is usually the result of hypovolemia for these patients. And this indicates that the situation is critical. Transport immediately to a trauma center. Do not delay transport. That doesn't mean that ABCs are not to be managed. Cushing triad. Look for a Cushing triad. Increased blood pressure, which is hypertension. Decreased heart rate, which is bradycardia. Irregular respirations or slow respirations. Pain Stokes respiration or bio respiration. Manage shock, administer oxygen, and ventilate as necessary, avoiding hyperventilation. Follow standard precautions. Oh, my bad. Emergency care that is specific for spinal injuries. Follow standard precautions. Maintain the patient's airway while keeping the spine in the proper position. Assess respirations and give supplemental oxygen. Managing the airway, perform jaw thrust maneuver, consider inserting an oropharyngeal airway, and remember that for your suspected spinal injury patients, the nasopharyngeal airway would be contraindicated. Have a suctioning unit available, provide supplemental oxygen. And that's our jaw thrust, manipulating the mandible without causing the neck to shift. Spinal motion restriction of the cervical spine. Immobilize the head and trunk so that the bone fragments do not cause further damage. Never force the head into a neutral inline position. We do not go against resistance in EMS. Immobilize the patient in his or her current position. Cervical collars. Cervical collars provide preliminary, partial support and should be applied to every patient who has a possible spinal injury. To be effective, a rigid cervical collar must be correctly sized. That is one of the challenges. Persons do not size the collar properly when applying it. Do not rush, cover your ABCs, stay focused, measure, put on your C collar. Don't be in a hurry. Do not be in a hurry. Move strategically to do what you need to do for the patient. And I have gone on scenes where I had to take the collar off and resize it because the EMTs that I was working with rushing. So that the collar is sliding over the patient, the collar is sliding over the patient's chin because it wasn't properly sized. Don't be in a hurry. Move strategically. Move strategically. So if you're sequential and you're systematic, you will be much faster than a person who is frantically trying to do a lot of things with no direction. Just move sequential. Be systematic. Don't let the people in the environment rush you or tell you how to do your job. Very important. Proper fit is essential in applying a cervical collar. The collar should rest on the shoulder girdle and provide firm support under both sides of the mandible without obstructing the airway or any ventilation efforts. Once the patient's head and neck have been manually stabilized, assess pulse, motor, and sensory function in all extremities, then assess the cervical area and neck. We will go through this in practical. Maintain manual support until the patient has been fully secured to the backboard or a vacuum mattress. Preparation for transport. Supine patients. Secure a long board or vacuum mattress. Another procedure to move a patient from the ground to a backboard is a 4-person log roll. That's going to be the one that you use most commonly. You may also slide the patient onto a backboard or vacuum mattress. And point to note, once you get a patient sitting, standing, on their side, on the belly surface, you have to put that patient supine on a spine board. Use your reasoning ability. If the back is already available to you, check the patient's back or do your rapid head to toe for the posterior portion of the body before you turn the patient over onto your board. So while you have access to the back, do your assessment of the back and then turn the patient over on your board. Every spinal injury patient or suspected spinal injury patient will have to be in a supine position at some point. That is your goal, to get them supine on the backboard, vacuum mattress, or scoop. That is your goal. Don't make anybody rush you. Do not allow people to rush you on the scene. Vacuum mattress. An alternative to the long backboard is a vacuum mattress. It molds the specific contours of the patient's body, and this device is very good for your geriatric population. Excellent for the elderly or patient with abnormal curvature of the spine, can be used on a supine sitting or standing patient. And I have never seen one here in Jamaica. Never. Doesn't mean that it's not here. I've just never seen one. Sitting patients. Use a short backboard to restrict movement of the cervical and thoracic spine. Then secure the short board to the longboard. Exceptions include situations in which you or the patient is in danger, you need immediate access to other patients, the patient's injuries justify urgent removal. Standing patients. So you see much positions you need to be familiar with to put a patient on a spine board. So if the patient is on their side, if the patient is on the belly surface, if you find the patient standing or sitting, you find the patient supine, if the patient is heavy, you need to be able to put that patient on a spine board or a spinal motion restriction device. Standing patients. Transfer patient to a position in which spinal motion restriction can be maintained. Clinical indications for spinal motion restriction, spinal tenderness or pain, altered level of consciousness, neurologic deficits, obvious spinal deformity, high energy trauma in an intoxicated patient, or one with a distracting injury. Preparation for transport, still continuing with that. Spinal immobilization devices. Assume the presence of spinal injury in all patients who have sustained head injuries. Very important. Use manual inline stabilization or a cervical collar and a long back board. Your KED, short backboard, or Kendrick extrication device. Short backboard, vest type device, and rigid shortboard designed to immobilize and restrict movement of the head, neck, and torso, used to immobilize non-critical patients found in a sitting position. Your long backboards, and my preferred one is the one to the extreme left, the scoop. This is what I currently use. I rarely use a spine board anymore. I use a scoop. So you see that I'm using a scoop stretcher or a scoop backboard. I do not use the backboard anymore. Long backboards provide full body spinal motion restriction, including the head, neck, torso, pelvis, and extremities. And if you're using a spine board, remember that the spine board is a full body splint. So if a patient has a fracture to their leg, don't delay putting the patient on the spine board because you want to stabilize their leg. Get them on the spine board. The spine board is a splint for the entire body. Don't delay transport of a critical trauma patient. Long backboards provide full body spinal immobilization and motion restriction to the head, neck, torso, pelvis, and extremities. Used to immobilize patients found in any position, which I've named all of those positions that you can find the patient in. You need to be able to put the patient in any position you find them on a spine board, supine, or a scoop. Helmet removal. A helmet that fits well prevents the patient's head from moving and should be left on, provided that there are no impending airway or breathing problems. It does not interfere with assessment and treatment of airway or ventilation problems, and you can properly immobilize the spine. If a patient has on a helmet and it is tight enough to keep the head steady and their airway and ventilation is not compromised, let the helmet remain on the patient. If ABCs are compromised, the helmet has to come off. And there's a technique to remove the helmet, which you, if I can find my helmet, I will let you practice that. Remove a helmet if it is a full-faced helmet. It makes assessing or managing the airway, if It makes assessing or managing airway problems difficult. It prevents you from properly immobilizing the spine. It allows excessive head movement. The patient is in cardiac arrest. Preferred method, removing a helmet should always be at least a two-person job. Should be more than that, but shouldn't be less than two persons. You should first consult with medical control about your decision to remove a helmet. Alternate method, the advantage is that it allows the helmet to be removed with the application of less force, therefore reducing the likelihood of motion occurring in the neck. The disadvantage is that it is slightly more time consuming. Alternate method, remove the chin strap, remove the face mask, pop the jaw pads out of the place. Sorry, pop the jaw pads out of place. Place your fingers inside the helmet, hold the jaw with one hand and the occiput with the other. Insert padding behind the occiput. And this is skill. I should have an old helmet, so I should be able to demonstrate this when we come face to face. The person at the side of the patient's chest is responsible for making sure that the head and neck do not move during removal of the helmet. Remember that children may require additional padding. Maintain the inline neutral position. And that would bring us to the end of this chapter.